This episode of To The Point is sponsored by Tarsus. Tarsus Pharmaceuticals applies proven science and new technology to revolutionize treatment for patients, starting with eye care. Tarsus is advancing its pipeline to address several diseases with high unmet need across a range of therapeutic categories, including eye care, dermatology, and infectious disease prevention. Tarsus is proud to announce that Xdemvy Lotilaner Ophthalmic Solution 0.25% is now available to prescribe.
Ocular surface disease. It's complex, chronic, and progressive, but rife with opportunity for the enterprising optometrist.
The mission of this podcast is to make this condition more understandable and accessible to those interested in specializing in it. So let's get to the point. Hello, everyone, and welcome to another episode of the To The Point podcast. My name is Jackie Garlich, and I am joined by my co-host, Leslie Odell. And we are joined by a great friend of ours, Dr. Jake Lang. Dr. Lang has been involved in dry eye clinical research and FDA trials for many years, including both medications and therapeutic devices. He writes articles for several publications on the topic and is actively involved in lecturing to colleagues at various meetings locally and nationally. He's a diplomat of the American Board of Optometry, a fellow of the Academy, and adjunct clinical faculty for ICO and for SALIS. He's also the residency coordinator for Associated Eye Care's optometric residency program and is actively involved in lecturing on eye care innovations and participates in ongoing clinical research. Lots of things. He's an amazing guy. We love him. Welcome, Dr. Lang. We are going to talk about thyroid eye disease today.
Yeah, thanks for having me, Jackie. It's good to see you.
We talk a lot about dry eye on this podcast, and you really can't talk about a dry eye patient without also talking about a potential thyroid eye disease patient and their correlation between the two. So that was one of our plans today, is to talk about the thyroid eye disease patient, who that patient is, what they might look like, and kind of go from there.
Yeah, definitely. Yeah, thyroid eye disease is, it's such a big thing and a growing concern for optometrists because especially as dry eye patient or practitioners, we want to take the best care of our patients as we can. And one of those roles as dry eye practitioners is really to make sure we're not missing any underlying condition that might be causing the patient's symptoms that are manifesting as dry eye disease. We all know how dry eye is rooted in inflammation, and there's so many systemic inflammatory conditions that can affect the eye. We have to, kind of be detectives and use our spidey sense to determine whether, this is just, I hate to say run of the mill or regular dry eye because there's so many nuances to this disease, but that there's not a bigger fish to fry underneath the surface.
I think that's a great point. I think as the technologies have rolled out and we've all been really eager to embrace dry eye in our practices, there's a lot of dry eye experts or dry eye centers of excellence that have popped up across the country, which is amazing to see. But I think it's important that all of these doctors not only understand the technologies that they're using to treat things like meibomian gland disease, but not to forget the whole patient. So I think thyroid, and thyroid eye disease is a great way to just really kind of say, to almost take a step back when you're looking at your dry eye patients. It's not always just situational with screen time and environment. Yes, we know things like Sjogren's syndrome, but thyroid is a hypo, euthyroid. I don't know what the numbers are, and maybe you can share that, but, there's a lot of my patients that are taking medication for thyroid disease. And so I think that, with the introduction of some of these new therapeutics, I've learned a lot even about grading scales and understanding thyroid eye disease. So I'm really anxious to hear a little bit more about that from you.
For sure. Yeah, I think we all see thyroid patients every day, right? Like every day I'm going to have someone on Synthroid or something, a very common condition that we see. But when we talk about thyroid eye disease, I've been spending a lot of time kind of reprogramming myself and my residents and students that I work with regarding Graves' disease and thyroid eye disease being two separate things. And I think we can start there when we look at Graves' disease as the most common form of hyperthyroidism in the United States, at least. The most common form of hyperthyroidism being that Graves' disease, where we think, oh, yeah, that's going to have eye problems, but not always. This hyperthyroidism is kind of this autoimmune inflammation that is activating the thyroid, thyroid stimulating hormones. So you have antibodies, thyroid stimulating antibodies, TSI, activating your thyroid. And we don't understand completely why this happens. Some people think it might be from a viral infection or some inflammatory condition that you had, or whatever happens to make your body make these antibodies, but it starts making these antibodies, stimulating your thyroid, and boom, your thyroid levels go through the roof most of the time. There are some patients where actually go hypothyroid and some people that are euthyroid. So really we kind of think of it as, really should be Graves' thyroid dysfunction, but most commonly it's found as a hyperthyroidism. But of those patients with Graves' disease, only 50% of them, or actually, that's a pretty high number, right? So 50% of them will develop thyroid eye disease sometime in their life. So half of those patients are going to develop thyroid eye disease. And when we talk about thyroid eye disease, we're talking about, again, that antibody attacking or stimulating inflammation in the orbit. So it's thyroid eye disease is the most common orbital disease that we see. So if there's something wrong with the orbit, just like if something's wrong with dry eye, 85% of the time it's going to be meibomian gland disease, and you can just treat meibomian gland disease all the time and be right 85% of the time. If you were guessing something's wrong with the orbit, most of the time it's going to be thyroid eye disease.
That makes me kind of think I might need to start, investigating this a little bit more, because, in the past year, I've had maybe a handful of patients that have been having enough symptoms that we've moved to therapy with new therapeutics with Tepezza. But just like everything else, as you get a drug and you start learning about the disease state, it increases awareness. And then something that might have seemed a little bit uncommon becomes more commonplace in your day to day. So what kind of things, especially when you're teaching residents, what kind of things do you teach them to look for when watering, right? Because I would say watering or maybe redness might be some symptoms that these patients might have that could have that overlap with your dry eye patients.
Yeah, the warning signs or warning symptoms, right? So huge amount of overlap with dry eye symptoms, right? So we're going to have, painful eyes, watery eyes, gritty, light sensitivity, inflammation, swelling, blurred vision, double vision, or diplopia too. So all these things overlap with dry eye. Some of the most common symptoms that the patient is their chief complaint at the diagnosis of their thyroid eye disease, the most common symptom, 57%, if you want a number, dryness and grittiness. Pain behind the eyes followed it closely with 54% of patients describing pain behind their eyes. So not so much the acute pain, the stabbing pain or the sharp pain that we see a lot of times with dryness, but more pain behind the eye. And then we talk about things like headache, light sensitivity, watering, following up that. If we look down the road with more chronic dry eye patient or chronic thyroid eye disease patients, still their number one complaint is dryness and grittiness, 47%.
Yeah, those numbers are pretty high, I think.
Yeah, they are.
43% of those chronic patients complain of itchy eyes. And that's something we should think about too. So warning signs that we'll see, again, allergic conjunctivitis that doesn't respond. I think we all know that, mast cell stabilizers and antihistamines and steroids work pretty well for allergic conjunctivitis. So I always tell my residents, like, if it's not responding, if it's not doing what it should be doing, you have to start opening up your differential and start thinking about other things.
So do you then start with labs, because those patients already know they have problems with their thyroid most times, I'm assuming, or you jump right to imaging?
I think it's interesting to do a little bit of both, actually. If you know what you're up against and you know they have thyroid eye disease, it sometimes interesting, not so much their TSH or T3 or T4. Like, I don't really care about that so much. It's the TSI levels. So that thyroid stimulating immunoglobulin is a lab you can order, and it's specific for thyroid eye disease, right? It's going to show you this immunoglobulin that is produced that's causing the problems. Because a lot of these patients will have their thyroid radiated and taken care of, and they're on Synthroid now and doing fine, um, but the eye stuff might still be going on. So that TSI, I think if there's a lab I'm going to order, that's going to be the one. And this TSH, T3, T4, 10% of patients with Graves will be euthyroid. That all that stuff's going to be normal, but they're still sick. So 10% of the time you order your normal thyroid panel and you're going to be wrong. So I find that one useful. I think the imaging is useful, but more and more, I think the new therapeutics just play a role because we know they're an option. We can get into that a little bit more. And
Yeah, I don't know if you're prepared to talk about it, and it's okay if not, but the CAS grading system, just to kind of see, and that might be the start, right? I think it's great, this lab that you're talking about looking for antibodies, but, maybe it's having this questionnaire and scoring the patient to know this is someone that I should be paying more attention to for the risk of thyroid eye disease.
yeah, so CAS score being clinical activity score. So there's a specific clinical activity score you can look up for thyroid, and it's similar. I think you can think of it similar to our speed scores, our DQ5 scores, and there's probably a fair amount of overlap. So if you're using those, you could use that kind of in your brain for their clinical activity score, right? That's their eye clinical activity score. The other warning signs, orbital congestion, so not really like a conjunctivitis, but congestion in the conjunctiva and the orbital tissue. So any conjunctivitis that doesn't respond the way it should, we should have our spidey sense go off um, about thyroid eye disease as well.
And that just drives home the point of follow up with your patients, right? I think that's something that can be so critical for these patients, especially, or some other, sometimes your neuro patients is just, if you're not sure, start a therapy, see them back, reassess. And if it's not moving in the direction you expect, then start thinking outside of the norms for that. But just real quick to talk a little bit more about that clinical activity score. This is a score that has 7 questions for what's called initial CAS. So that is this pain that Dr. Lang's talking about, spontaneous orbital pain, gaze evoked orbital pain, eyelid swelling that is considered to be active due to Graves' eye disease, eyelid erythema, conjunctival redness, again associated with Graves, chemosis, or inflammation of the caruncle, which is, so of these you score, how many of those 7 does your patient have? 1 point is given for each presence of those parameters, and then it's just the sum. So if your score is 3 out of 7, I guess that's pretty consistent with the consideration for thyroid eye disease. Then it goes to look at other things. If you follow that patient after a month to 3 months, they look at proptosis, which would be one of the more standard things that you'd be thinking of with progressive thyroid eye disease. So an increase in 2 millimeters of your proptosis, or any kind of misalignment of the eye muscles, like he was talking about with diplopia, or even a decrease in visual acuity. So I will say my experience with Tepezza, our infusion therapy now for Graves' disease, and Graves' disease is a little bit limited, but I do have one patient that I'm sure is similar to patients that you've seen, Jake. And I think she actually even was sent to me for a dry eye evaluation, and presented, if I remember correctly, with conjunctival redness and some watering. And we started treatment, at that point, it really did look like it could be dry eye. And then as I was seeing her back, she started eliciting diplopia. And I'm thinking, something is definitely not your standard dry eye.
Leslie, when the patient says diplopia, are you like, can you blink and get that to be single? I would always try this as a student. So I was like, oh my gosh, I really don't want to deal with diplopia. Like, is it big? Can you blink?
This episode of To The Point is sponsored by Tarsus. Tarsus Pharmaceuticals applies proven science and new technology to revolutionize treatment for patients, starting with eye care. Tarsus is advancing its pipeline to address several diseases with high unmet need across a range of therapeutic categories, including eye care, dermatology, and infectious disease prevention. Tarsus is proud to announce that Xdemvy Lotilaner Ophthalmic Solution 0.25% is now available to prescribe.
Are you sure it doesn't go away when you cover your eye? Yeah. Yeah, I mean, it definitely throws a wrench in the schedule, I'll say that. So it's kind of nice when you do bring those patients back to plan accordingly. Like we had talked in a previous podcast, maybe you don't want that patient right in the middle of your morning. You might want them to be your first patient after lunch, so that you have time to kind of get behind when you're doing your spidey sense problem solving. But so what I was really impressed by, so I worked with an orbital specialist in my area to get this woman on Tepezza, the infusion therapy. And I saw her back actually because of a, an unrelated side effect that happened soon after that first infusion. But I was really amazed with how quickly she responded. And that's what I'm sure that you can kind of talk to with your experience too. And, I had her basically patched or maybe in a Fresnel prism at the start of this. And I mean, within the first 1 to maybe 2 infusions, the diplopia was now managed without any prism. It was really remarkable.
Yeah, isn't that great? Like when we actually can fix diplopia instead of just hoping it goes away when we blink. It's pretty cool. So yeah, teprotumumab or Tepezza came on the scene a couple of years ago now. I think it's already been. Jackie, we had brought it up at one of our academy lectures when it was just getting close, but really cute, cool medication. It targets insulin growth factor 1 receptor, which seems to pair with the thyroid stimulating immunoglobulin and activate fibroblasts and inflammation in the orbit. So that's kind of how it works from my lowbrow thinking perspective. But really cool results with this. Reduced proptosis, like you had said, 83% of patients versus 10% of patients on placebo. Improved clinical activity score in 70% of patients. Diplopia decreased in 70% of patients as well. So really seems to work really well. And not everyone is as quick. There's 8 infusions given over in 3 weeks in between, or every 3rd week you get an infusion for 8 total infusions. And the results are pretty impressive.
Now, in your state, are you able to work with an infusion center yourself and just order?
We could, yes, we would be able to do that in Minnesota and Wisconsin. I personally like them to have more cooks in the stew when it comes to these patients, because it is being such a systemic condition that I want the endocrinologist involved, and I think there's a place for our oculoplastic specialists. And honestly, we're blessed in the Twin Cities Metro to have some really amazing oculoplastics people. And just like I can't take care of everything, I don't expect that optometrists should take care of everything. That we're part of the team. So I think this is a really great time for us to be team players and play nice with everyone. So that's what I do, is I would get them involved and let them handle it. But I can help out with the dry eye, and I can see the patient more often than the oculoplastics person can to help them through that process.
Yeah, that's what I've done too. I've been teaming up with oculoplastics in this area just because it seems like the easiest way, and they had the most experience at the time. And I think this launched during COVID, because I remember seeing you, Jake, talking about it virtually with your TED Talks.
Oh yeah, yep. A lot of virtual talks, but It also has a pretty good effect now that it's been out for a while. Tepeza's being used more on chronic patients. So we think about like the early and kind of active phase of this thyroid eye disease, and then kind of this chronic, where they would call it inactive phase, where their clinical activity score is low, but they still have the proptosis and the diplopia and the severe dry eye and exposure stuff. And Tepeza's been shown to help those patients too, even patients that have had a thyroid eye disease for 10 years, that they're treating these patients and getting a really great response. So now that it's been out for a while, we're seeing improvement there, which, really begs the question, that I kind of want to go back to dry eye. When we think about dry eye, that inflammation is kind of there, no matter what. And the same thing with thyroid eye disease, even though it's been stable for a long time, that inflammation seems to still be there. And there's this activity going on that's messing up our orbits. And my kind of feeling from the case series I've seen is it's still there and still going on. And maybe it needs to be treated no matter what. So we'll see where this goes, but it might be that everyone that's ever had thyroid eye disease needs this drug to get them to a stable place, and then we can deal with things from there.
Yeah, definitely an interesting perspective. I think just even with, not to complicate this, but I most recently had another dry eye patient that was sent to me, and same thing, watering, I believe, was the first presentation. And then diplopia started. His eye was very proptotic, but it was only one eye. I actually shared his care with a neuro-ophthalmologist who was like, I'm convinced this is thyroid eye disease. Like, it's going to be so great because we'll get him on Tepeza. It's going to be great. It's going to fix it all so quick. So we get the imaging done, and it came back cavernous sinus fistula, which
You
I'm
told
thinking,
me about this one.
This is not your typical dry eye referral, but it definitely gets you thinking, not only does dry eye make your eye water, that's what I'm learning.
Yep.
Yeah.
Yep, exactly. I had a similar case last week that was sent from an optometrist for left eye dryness, right? So monocular dry eye. And he had a lot of dermatochalasis that was hiding his proptosis on the one side. And if you didn't just sit and stare at him while he talked to you, and I was like, left eye, left eye, left eye, left eye, and I'm just staring down that left eye, because of his dermatochalasis, I don't think I would have caught it just, at first glance. So something that the spidey sense has to go up when that happens.
So Leslie, the reason I was asking about were your patients' dry eye symptoms improved is because we know, just because they have thyroid eye disease doesn't mean they can't also have dry eye. And so I think that, to come full circle with this, I think it's a good point to sort of start with this, to have that at top of mind. I mean, I think I felt the same way about Oxervate when that got approved, is that once I really started checking corneal sensitivity more, I realized more was out there than what I really thought of before. And so I think, just keeping thyroid eye disease at the top of mind. And if you're, starting to treat someone and they're not improving, you have to really sort of take a step back and really assess that patient and see, okay, what am I missing? What else is going on here?
100%, 100%. So yeah, I agree. And then when we are the hero of the day and diagnose this thyroid eye disease and get the patient the appropriate care, we have to remember that they're still going to probably need dry eye care. This, isn't going to necessarily cure their dry eye, or we at least have to help treat their dry eye through their journey of thyroid eye disease. So we have to be there for them from that standpoint. It doesn't exclude the dry, like you said, Jackie. Great point. The other big thing that I wanted to touch on is smoking. Graves' disease, so that thyroid disease, and smoking is a huge risk factor, like 5-fold increase in thyroid eye disease in patients with Graves' disease that smoke. So smoking can be a huge problem, and anyone we see with the diagnosis of Graves' disease should be educated by every healthcare provider they see that they really can't smoke. Like, I bring this up a lot with patients, and most of them say it wasn't on my list of things to do today, to take up smoking, but they really need to know the risk. Like, smoking is way riskier for you than the average person. Yeah, such a debilitating disease from, quality of life and appearance. So, anything we can do to prevent is huge.
I would just say one, final thought for me when you talk about the care team and how you said, sometimes it's good to have that team. This is a great example why, but not only does that help, it's going to help actually generate more referrals for you, not only for your dry eye clinic, if you will, but just being able to manage these patients with thyroid eye disease. So great outreach to endocrinology, right, and primary care, and even then the oculoplastic specialists in your area. I think it's a great way to just really set yourself apart.
That's a great point. Yeah, all those oculoplastic doctors don't want to deal with dry eye. They may, have a lot of patients with dry eye issues, and if you make a good working relationship, that's a great point, Leslie.
All right, Jake, thanks so much for joining us and talking to us about your favorite topic, thyroid eye disease. We appreciate you sharing your expertise with us. Thanks so much for joining.
No, thank you for having me, ladies. It was always a pleasure to hang out with you guys and chat eyeballs. So thank you for the opportunity. Hope to see you in person soon.
And now for the To The Point wrap-up. Thyroid eye disease is a condition that often can mimic symptoms of dry eye, with watering and redness as some of the earliest symptoms. Remember this when you're treating your dry eye patients, to think systemically and not just stay localized to the eye. New treatments with Tepezza have greatly improved quality of life for these patients, and early intervention can really impact outcomes.